Welcome to the College Connection podcast, a podcast presented by the College of Registered Nurses of Newfoundland and Labrador. This is the College Connection podcast.
Welcome to the College Connection podcast. The College Connection podcast is made available to registered nurses and nurse practitioners as a resource to promote good practice and to highlight the importance of regulation in healthcare. My name is Kelly Kane, and I'm a registered nurse and a nursing consultant with policy and practice at the college.
And I'm Michelle Carpenter. I'm a registered nurse and a nursing consultant for policy and practice at the college as well.
Today, we are continuing with part 2 of our conversation with Newfoundland and Labrador Health Services CEO, Dr. Parfrey. Let's jump right back in where we left off. So, Dr. Parfrey, it's difficult to tune into the local news media these days and not hear stories about travel nurses and travel agencies. Can you give us your thoughts on travel nurses, and can you talk a little bit about the reliance that, or is there a reliance, I guess I should ask, that Newfoundland and Labrador Health Services has on travel nurses?
There is a reliance, and during COVID, when we had the drop in the number of providers and the number of nurses that were available to us, and after COVID, a lot of nurses pulled out. So you didn't have enough nurses in the population to be able to provide the services that we needed to. And I think that we had to try and get some solution to it. So that the agency nurse was a very expensive solution to try and provide services when we didn't have enough nurses. However, it's our policy that we're going to decrease the number of agency nurses that are in use in the various places. And it's central and western of the areas where we've got the most number of agency nurses, because that's the most difficult place to recruit from.
Right. So
we have no intention of decreasing services. So we end up depending upon travel nurses. Now, we've reduced the amount from its peak. We're now down by 40%.
Mm-hmm. Right.
But we're still paying a substantial amount of money for travel nurses, of 120 million probably. The recruitment of nurses has improved substantially this year.
Right.
So the number of vacancies that we have this year is 300, which is down from a peak of around 700.
Right.
So you can see that the balance of the requirement or the requirements have decreased. And I think the contracts that we're negotiating are more favourable to us than they are to the agency companies. And the next piece that will happen, I think, will be the nurses and providers that come out of the educational areas in the next year.
Right.
Will put us in reach of being able to not depend on agency nurses.
Mm-hmm.
So I'll give you an example of what we have to toss up, right? So in cardiac surgery, we have an agency nurse who's excellent.
Right.
And we need that person to be able to provide the cardiac surgery. We can't say, we're not going to have you, and we're going to allow the number of cardiac surgeries drop and the wait lists go up.
Right. Mm-hmm.
So that's the thought process that you have to evolve.
Mm-hmm.
But it's our intention to try and decrease the need for agency nurses as much as is humanly possible.
Mm-hmm. Right. Mm-hmm. And we have done a podcast with Colette Smith on the retention and recruitment and retention of registered nurses in Newfoundland and Labrador Health Services. So obviously, as you said, there are initiatives in place to help address the need, and so that we don't have that reliance on the agency nurses. Mm-hmm. Can you speak a little bit about that and some of those initiatives that NLHS is doing for recruitment and retention?
I think you ask Colette. She's better. She's a human. She knows better than I do.
Okay.
However, I can comment that the area where we have difficulties in recruitment is in central and western.
Yeah.
So and we don't have it as much of a problem in eastern, even though we have agency nurses in difficult places. Right. So the capacity for nurses who come out who say, I want to work in St. John's only, and the work is in central or western,
right.
That's the piece that's difficult.
Right.
Teachers do it, right? And then they work to come back to be able to do so.
Right.
And that is a reality. If the city is full, then you have to think, if you want to stay in Newfoundland, then you choose another area.
Right.
So I think that piece is our challenge.
Right. Thank you. So a number of new healthcare facilities are being constructed. The new mental health and addiction center just opened, and we were lucky to get a tour of that facility. The planned replacement of St. Clair's Mercy Hospital and proposed urgent care centers are some examples of some of the new infrastructure. How are these healthcare investments impacting access to healthcare?
They're not impacting them at all because they're not built. So there's obviously a delay in
Yes.
in being able to provide bricks and mortar.
Right.
So if you take the ones that you mentioned,
Yes.
the mental health and addictions piece, that building is a fantastic building.
Right.
It's 102 beds. There's and plus 14 at the Health Sciences Centre in addition. So you've got 116 beds for mental health and addictions in a fantastic facility with the most amazing artwork I've seen in a hospital in my life. And I think
Right.
it's totally correct that they use artwork to create a more joyous environment.
Right.
And it's particularly suitable for mental health people who are there for quite a long time and have to get their drugs sorted out, etc.
Right.
So that opens and the transfer patients on the 14th.
Right.
And then you have the issues around community programming, which is going to grow, right? If somebody has a psychotic episode and they need drugs and they need them tailored and all the rest of it, then you need to make sure they take them. So the ACT and FACT teams are the ones that ensure that you've got community resources available to help there.
Right.
But the kind of the more and the fulfillment of the mental health services that are necessary also requires that health and wellness centre on the Grace site.
Right.
Because as it visualises having beds for step down care for psychiatry and detox beds for people who have addictions.
Right.
And then that would be the site of where the community-based resources would be there for psychiatric illnesses.
Right.
That'll probably take 3 or 4 years.
Okay.
Right. So
Right.
so that part is moving. And then the next part that you brought up was around the urgent care centres, I suppose. That's the piece that's one at the Costco building and one at Blackmarsh Road.
Right.
So the staffing of those will be a challenge because they're new places, and they're probably targeting, in effect, walk-in clinics is what
Okay.
they're trying to do.
Right.
Emergency would still go to the Health Sciences and to St. Clair's, but you end up having to educate the population that if you're level 3 or 4, that's the place to go.
Right.
Right. So I suspect there'll be delays in ensuring that people actually use those facilities rather than going to emergency rooms, which we want them to do.
Right.
So they're down the line.
Yes.
And then the next piece is the acute hospital complex
Yes.
or campus.
Yeah.
So the vision there is that St. Clair's is an old building, and that the services St. Clair's provide internal medicine, surgery, and orthopedics in general. They've also got other programs, but those kind of regional hospital types of services
Right.
would go there. But then the Health Sciences Centre is old, and that's where the tertiary care services are. And the vision is that they would go to that site as well. And you probably need all of those, and the cardiovascular and stroke program has a new centre envisaged.
Right.
And the tertiary services interrelate, so you want to transfer them at the same time.
Absolutely.
So we've got this vision of having a campus that's probably 600 beds,
Oh, okay. Yeah.
and probably 4 or 5 buildings, and probably a 10 to 12 year horizon, and a massive budget,
Yes.
because that's really expensive.
Yeah. Absolutely.
So we still have the challenge of being able to provide the resources and the facilities that we're in.
Right.
So this question of how do we deal with overcapacity and how do we use acute care beds and how do we use transitional care and restorative care appropriately, so that we're using the beds at the Health Sciences in particular for acute care, that still remains the challenge.
Right.
So,
Yeah.
and then there's more than just the hospital. You've got the faith-based homes here require renovations.
Absolutely,
That takes time. Then there are in other places in particularly in Western and Central and Lab Grenfell, there's a need for personal care homes and long-term care to be able to meet the need of people who are getting frail and can't live at home any longer.
Right.
So there are very challenging infrastructure requirements for the province.
Right.
And thanks be to God, we got that deal with the Churchill Falls.
Right. Yes, hopefully we'll have access to more funds. So, Dr. Parfrey, I guess it's going to require some patience on on us as a population, but it's motivating to know that there's plans in place and that access will increase. But I guess it's requiring NLHS to be creative and innovative with what we have now while we get to that point where we have these new facilities.
I think we'll end up having to be creative all the time, really,
Okay,
right?
yeah.
So, I mean, if that campus comes to fruition, that's 12 years away. I'll be dead by then.
You may not. You never know.
But you know what I'm
Yes,
saying. Like,
absolutely.
My job is, I suppose, is to ensure that facility meets the needs of the teams that are going to use it.
Absolutely.
But on top of that, meets the needs of the population for care.
Right.
And the bigger challenge is, what are we doing in the interim
Absolutely.
to ensure that we have we got better access to emergency rooms, we got better access to imaging, we got better access is our problem.
Yes.
Right, and working to ensure that those things happen.
Right.
Yeah.
So you have a lot on your shoulders.
Yes. So NL Health Services is responsible now for all of Newfoundland and Labrador, and we have a sprawling landmass with very sparse populations in some of those areas. How does NL Health Services meet the needs of such a diverse province, geographically speaking?
Well, I think in the previous podcast I suggested the major components of it. So if you think of Bayvert, for instance, it's 2 hours from Grand Falls.
Right.
It's got one doctor, and it's got its family care team has started, 5,000 people. So it needs to have another doctor and a nurse practitioner that look after 2,000, and a nurse, that's 2,800 patients would have a provider by that. Right. So they need double that.
Right.
And then they need other types of providers or access to other types of providers for that population. So that family care team is improving. And the capacity then to be able to use virtual care. Virtual care is critical. People are saying, I got to see a provider. You don't actually have to see a provider every time.
Absolutely.
You need to see a provider when you need to be examined. Right? You don't need to see a provider, you need to be listened to.
Right.
So I think that we have to embrace virtual care. And then the other key thing is the ambulance system.
Right.
So the people there have to believe that if something bad happens, that ambulance is available and it gets into Grand Falls as fast as possible. So that kind of solution to more isolated communities is feasible, I think.
Yeah, absolutely. And I think it's going to take education of the public about those type of services that are available. And I go back to just talking to my mom about a week ago when, she was suffering from what she thought was pneumonia. And, she went to the, Grand Bank Hospital and waited 8 hours to see, a physician. And, my comment to her was, Mom, well, there's other options out there. You can call into 811, and there may be virtual opportunities. So I think it's going to come down to the public embracing new ways of healthcare delivery. What's your thoughts on that?
Well, I think that you're saying what I've just said, really, at one level. So the way Teledoc works is that we have a provincial contract for Teledoc to deliver services for emergency care and continuing care. Right. And we offer the services on top of that to people who don't have a doctor, who are connected to Patient Connect or registered with Patient Connect.
Right.
So the way it works is that the nurse would there's a contract bought, there's a doctor available. You get, from what I can gather, you can get to speak to a doctor within 60 minutes of them communicating with Teledoc.
Right.
And you've got the doctor in front of you, who's a human being, who speaks to you and all the rest of it. And then there are things that can be done by the nurse, like blood pressures and weights and all that stuff. And the nurse can examine the patient. And then they can make a decision about what would happen in Grand Bank, and I would suggest that the number of people that would need to go to Buren Hospital as a consequence of that examination pretty small.
Right.
Right, your mother probably wouldn't have needed to go to Buren Hospital just to be reassured or whatever, or given advice about how to look after herself.
That's right. Yeah.
So that I see nothing wrong with that solution, to be quite honest.
Absolutely. So, just as a follow-up question, so how do you see the role of virtual care in the years to come? How do you see that? Do you?
Well, my eyes were opened about virtual care when I was talking to a physiotherapist who said that he can provide virtual care, believe this now, virtual care for physiotherapy in the south coast of Labrador.
Wow, do tell.
Yeah.
I'm quite interested in how that would happen.
Because they were able to demonstrate what was necessary virtually and give them the programs and encourage them with what should happen and follow them up, etc.
Wow.
And now clearly for physiotherapy, which is so much hands-on,
Yes.
that you wouldn't be able to give 100%
No.
thing, but you're able to give quite a substantial amount that'll be of benefit to the patient who's in an isolated area, like where the south coast of
Absolutely.
Labrador is isolated.
Absolutely. I mean, that's really interesting because, there's so many wait lists and, you hear about physiotherapy and you might have to wait 3 weeks before you get in or longer just to get your initial assessment. So if we can move those type of services, not only to, that profession or others, that's amazing that to be able to get that care while you're waiting to see someone in person. So it's great. And maybe you don't even need to see someone in person, and maybe what your needs are can be addressed virtually.
Right, particularly if it's been the decision of another practitioner that actually saw you.
Right.
So let's take low back pain, for instance,
Absolutely.
right? Something which a physio can do very well.
Right. Excellent.
Yeah.
Yep.
It's about, I guess, virtual care not really being in place of the hands-on care, but virtual care when it's appropriate.
It's integrated.
Integrated,
Yeah.
right, absolutely. Yeah.
So the example I have used a lot would be if you're living in Nain
Yeah.
and you get a breast lump
Right.
Yeah.
and you need to see a surgeon about it, the initial assessment does not have to be done in St. John's. The initial assessment will be done in Nain, virtually. So
Right.
virtual first would be the initial contact. And then the surgeon will say, you need to come to St. John's now and you need this CT or this radiology thing and you need to see me.
Right.
And then that could all be done in one visit if it's properly organised, not two visits.
That's right.
Or they could have the CT in Happy Valley Goose Bay.
Absolutely.
Right? So that's a visit saved again, and the virtual connection we made with the doctor. And the doctor goes down, breast lump was taken out, and then the follow-up visit does not need to be done in St. John's.
That's right.
It can be done virtually.
Right.
With a nurse. Like a nurse is well able to look at a wound.
Right.
You know what I mean?
Yes, absolutely.
Yeah.
So when you think when I say the word virtual first, particularly for Labrador, I think it's the right thing.
Right.
And it kind of goes back to exactly what you said right at the beginning. Maybe it was in part one of our conversation about the right person providing the right care at the right time.
Right.
Yeah, absolutely. Dr. Parfrey, you have a monthly media availability, and that's a level of accessibility that we really haven't seen before. What steps have you taken to engage with the frontline staff of NL Health Services?
I have a monthly provider availability. And I did it this afternoon.
Oh.
And there was the average attendance, I've done 3 or 4 of them every month. The average attendance is about 1,200.
Oh, wow. That's
Right, so I am doing my duty for the providers. It works in a way that we might have today we had a 5-minute presentation by Glenda Weber about the new hospital, the new mental health hospital. And then the remaining 55 minutes was up for questions and answers, and they could ask whatever they want. There was no bar to whatever they wanted to ask. And I responded. So there'll be another one in a month's time.
Okay.
And that's really great to know that I guess the voice of those on the front lines is being heard, and that they have an opportunity, because it's not always easy to speak to the CEO of the organization. So having that availability is is groundbreaking, and good on you that you're able to, provide that opportunity to hear from those who are providing care right at the bedside.
So there is a disconnect between the workers, in particular group units. They over 80% think they've got a good team and they're happy in their work with their team.
Right.
40% have trust in the management of NLHS. And to me, it's looking at the team we've actually got a good team.
Right.
So it's a bit misplaced, I think, which means then that we have to engender the trust at a higher level for the people who are at the front lines.
Right.
And that's kind of part of the logic between having media availability, so that the media trust what you say and that you tell the truth.
Right.
And you don't avoid the hard things.
Right.
And then the same thing goes with dealing with the providers, that let them have the freedom to ask whatever they like and don't avoid the hard things. And if you don't know the answer, if I don't know the answer, sorry, I don't know the answer.
Right. That's right.
I'm human.
Yeah, absolutely. Yeah. So, Dr. Parfrey, you're a physician. You're a regulated healthcare professional. Regulation, specifically healthcare, is under microscope, and it's increasing. So, how important is the role of regulators in healthcare?
Well, of course, they're critical. I can only speak for the one that regulates us,
Right.
which is the college. And you really have very little contact with them unless there's a problem arises.
Right.
And if a problem arises, then the patient who complains about the treatment you give has the right to be able to make the complaint.
Right.
And to have it and to expect that it's dealt with objectively and that both sides are listened to, and the college then makes a determination whether there's fault or not fault.
Right.
And then on top of that, the patient has the right to a legal opinion.
Right.
And to take something that's happened to them to get recompense through the legal system. So I don't think that we should be avoiding that. And then if there's egregious activity, the college needs to act upon it.
Right, absolutely. And like registered nurses, nurse practitioners, you have a title as a regulated healthcare professional of doctor, and by having that protected title, I guess it gives assurance to the public that you're going to provide safe, competent care, as do I as a registered nurse, or Kelly as a registered nurse, or our nurse practitioners. By having that protected title, there's assurance to the public that you're going to provide safe, competent, compassionate, and ethical care. And we do that by ensuring that we have standards of practice, that we have a code of ethics, that we have regulatory expectations, practice expectations laid out in our documents. So it's really important that registrants know those requirements and apply those requirements.
Right. So I think that it is really important for us in this day and age to provide civil, compassionate discourse.
Right.
Not only between ourselves and patients, which is probably easier, but between ourselves and fellow providers.
Absolutely.
And the capacity, the incivility that's actually occurring within our system is very disappointing.
Right.
And my expectations are that we have to work on being more civil and work on being more compassionate, both with patients and with each other, and that the management system actually needs to also have those expectations.
Right. Yeah, absolutely. And in our standards, there is an expectation of having that civility and having that respect. It's professionalism, right? Having that professional presence and modeling professional behavior. So there is that expectation from the regulator. It's troubling when we hear that there's incivility, but I think is like doing podcasts today with you and with Colette Smith, talking about cultural awareness and incivility in the workplace. And we're doing a podcast with our Director of Professional Conduct Review, so that we always keep that top of mind. We're getting that message out so that registrants will have that information. Because at the end of the day, as you said, interprofessional collaboration and respectful communication goes a long way.
In the best interest of the client.
Absolutely.
So, Dr. Parfrey, thank you so much for this really good conversation today. We look forward to the future of healthcare and the role of NL Health Services. What elements, just to finish up today, what elements would you say are key for an effective and efficient and accessible healthcare system for all Newfoundlanders and Labradorians?
Well, I think to answer that question properly, read the health accord. However, being involved in it, I think that we have deficits in our care delivery in several areas. Our access to family doctors is definitely improving. The family care teams, at its peak, there was 96,000 people in Patient Connect looking for a family doctor.
Right.
It's now 46,000.
Wow.
The family care teams have enrolled 75,000 people.
Mm-hmm. Right.
So there's that access issue with family doctors improving bit by bit.
Right.
That's what people want.
Right.
We've mentioned the ambulance system that's being integrated. It's not exactly as we want it, but one of the things we really want though is we want to have not only integration of there in the ground, but we want to have a clinical system that allows a virtual doctor to communicate with an isolated provider in Nain with a sick patient to advise that patient, connect that person with the person who'll deliver emergency care, and that triangular conversation takes place about where does this patient go,
Right.
and that virtual provider then organises the asset and organises the bed,
Right.
and keeps in communication with the patient and the provider until such time as that patient arrives at their destination.
Right.
We don't have that,
No.
but we are going to go and try and get that. So that to me is really important, particularly in people who are in isolated places. So you've got the community end of it that we need to rectify. The long-term care end of it, we know from the Personal Care Home Auditor General's report that there are major problems. We know from the report on long-term care that the focus on quality of life and quality of care is critical. Right. So that's an area that we need to rectify. We can't just leave it be. We have to rectify it.
Absolutely.
And then when you get to the hospital system, you've got access problems with the emergency rooms. We have enough things coming online that I would see it improving, but at the moment it's not good.
Right.
I mean, if our first contact with the emergency room in the health sciences, which is being rebuilt, is not a good contact because it's being rebuilt and there's delays, etc.
Right.
And then you've got the capacity to get into hospital,
Right.
which is a major issue for us, access to the hospital. And then you've got the pieces that are deficient are seniors care,
Right.
geriatrician approach, non-medicalized approach to coming to end of our lives, getting that sorted out. We're
Right.
deficient in that area, and bit by bit we'll get better. The biggest things that affect us are cardiac disease, so the cardiovascular and stroke program needs to be effective in being able to ensure that they can give the appropriate treatment to every patient in this province. It's a challenge.
Right.
Cancer care, we're the highest deaths from cancer in this province. Prevention is related to the screening programs.
Right.
It's St. John's based, and how do we have outreach to other places to allow cancer care to get better? So you can see that I've already told you a whole pile of things.
Yeah.
You know what I mean?
Yeah, absolutely.
And I don't believe that you can neglect all of them.
No.
So the pressure is not so much on the person on the ground who's delivering the program.
Right.
They're there.
Right.
Their job is to deliver that particular program.
Yeah.
The pressure comes on the people who are responsible for multiple elements of a care delivery, and they're overworked.
Right.
Like the managers who are managing too many people, and the directors who are managing too many programs.
Right.
So that kind of part is a pretty big challenge.
Absolutely. Well, it's very reassuring that we have the health accord. We've done our work. We know where our deficiencies are, and that NLHS as vocalize that they are, dedicated to implementing those things so that we can get and address those social determinants of health, and that we're meeting the needs of the Newfoundland population.
We're not meeting them yet.
Not yet.
But we have a plan to meet them.
Absolutely.
Yeah.
And that's reassuring. So I guess the message is that we'll get there. It's just going to take us time.
Well, we always said that.
Yeah.
I mean, it's not possible to get the number of providers we got by taking them off trees.
No, absolutely.
They're not hanging up in trees.
No, that's right.
They're in nursing school or a medical school
Yeah.
or in a training program, etc.
Right.
So that capacity takes time.
Right.
And anything to do with bricks and mortar takes time.
Yeah.
Right. So it's and we've kept the fact that we can see improvements. Like NLHS is 2 years old a few days ago, the 1st of
Yes.
April.
Right.
And the fact that we can actually see benefits already, and the benefits I see are the family care teams that all the patients they've enrolled. The number of the cardiac surgery waitlist is down from 210 to 160. Number of joint replacements has gone up by nearly 50% last year. And I can go on and on.
Right.
That there are, and the occupancy of the hospital, even though it's a massive issue for us, nonetheless, it demonstrates that we're providing more care to patients than we have done previously.
Right.
So people, rightfully, I think, can be critical of components of it.
Right.
But I think we are making progress.
Okay. Thank you.
Excellent.
Excellent. Okay, well, that concludes part 2 of our conversation with the NLHS CEO, Dr. Pat Parfrey. Thank you, Dr. Parfrey. It's been a pleasure speaking with you today.
Same here.
And we thank you to our listening audience for tuning in. Remember, all episodes of this podcast can be put towards your continuing competency requirements. Also, remember to subscribe to our channel, and we encourage you to like, review, and leave a comment wherever you can. Thanks, and have a great day.
Thank you.
Thank you. Thank you, Dr. Park.
Bye to everybody.
This has been a presentation of the College of Registered Nurses of Newfoundland and Labrador.